The Birmingham Cognitive Screen is a new test instrument developed to screen participants for any cognitive problems after their stroke or other brain damage. The test lasts about an hour and allows an overview of the intact and impaired cognitive processes in the participant. The Birmingham Cognitive Screen is clinically applicable within 3 months of stroke to provide an early, broad-range cognitive assessment to inform rehabilitation management. The tests cover 5 domains, including language, covering assessment of speech impairment, reading impairment and writing impairment, mathematical and number abilities, including assessment of number reading, number writing and calculation, praxis control and planning of action, which includes the testing of gesture recognition, production and imitation, and action organisation, memory, which includes assessment of orientation impairment and episodic memory impairment, and finally, attention and executive functions, including assessment of spatial attention and controlled attention. The advantages are that it is comprehensive and inclusive. For instance, the tests are laid out to be as neglect-friendly as possible, so stimuli are arranged vertically rather than horizontally. This reduces the possibility of contralesional omissions. The tests are designed to be as aphasia-friendly as possible. So where tests do not specifically target language, we use high-frequency, short words that most people are able to understand. Where possible, we present stimuli both visually and verbally, and where possible we used forced choice administrative procedures to minimise problems due to poor word finding. The tests are designed to be quite sensitive within their domain. For instance, the reading tests examining irregular words use quite difficult, low-frequency items, the aim being to pick up a problem if one exists. Performance on each task is classified as intact or impaired. If further investigation is required, the impairment profile can act as a pointer towards more detailed diagnostic tests, which can be found in Birmingham Cognitive Screen 2. Many of the tests have a stop criteria, indicated by a bold line, where the test is stopped if the participant does not pass the first few items. The overall score takes such difficulties into account. This reduces the number of failures experienced by participants who have difficulty with particular tests. It also shortens testing time. To administer Birmingham Cognitive Screen, you'll need the following: printouts of the test booklet, examiner booklet and participant booklet, objects for the praxis test, player and speakers for the auditory material, a stopwatch and pens. Only the test materials immediately required should be placed on the table in front of the participant in the centre of his or her visual field. Ideally, the examiner should be seated in front of the participant, across the table from them. You should check that the participant has their reading glasses if required. Now let's take a look at the examiner's booklet. On page 1 of the examiner's booklet, you'll find the order of tasks to be administered. This order needs to be followed strictly. The first items are the orientation questions. These are followed by the language tasks, tests 2 to 5. We then present the first verbal memory task, task 6, which will be repeated later in the test session, task 12. The tasks that lie in between these two memory tasks are non-verbal or performance-based tasks, which are intended to minimise the effect of interference that could contribute to decay in memory, and also to ensure that a minimum of 10 to 15 minutes elapse before the delayed recall. There is also a functional memory test. This is test number 17. Although the test should ideally be given in a single sitting, it is possible to break the administration into 2 sessions. It is important, however, that tasks 1 to 17, that is, up to the task recall and recognition test, are given in one testing session, about 35 minutes. Tasks 18 to 22 can be conducted on a separate occasion, ideally not more than 4 weeks after the first session. The tests can be conducted at the bedside, but if possible, they should be given in a quiet room. Now turn to page 2 of the examiner's booklet. All subtests on the examiner booklet have a table, shaded in grey, containing a number of important administration considerations for each of the subtests. These include general instructions for the specific subtask, along with information on the material required, timing instructions, and specific instructions for participants with aphasia. The instructions on timing have two components. Firstly, timing restrictions for each item on the task, or for the whole subtest, and secondly, instructions to stop the subtest and move on to the next if participants are unable to respond correctly after a certain number of items, as indicated by the bold line, or after a certain period of time. It's very important that you read through and are familiarised with these instructions to ensure the reliability of your assessment and scores. Following the instructions are the test items and space to record the participants' responses. In case of an inaccurate response, instead of just entering a cross beside the item, please record the response in as much detail as possible. This is because the nature of the error is often very diagnostic of the type of deficit. A table is provided at the end of each task for entering test conditions and scores. The common rules for coding or scoring include: first, condition of testing. This is the box at the top of each scoring area. If the subtest has been administered without any modification, this is coded as 1 or normal. This applies even when the participant performs poorly on the actual test. 2. If the subtest could not be administered, the reason for not testing or modified testing is coded accordingly. For instance, a code of 6 is given in a writing or copying task if the participant is unable to hold a pen due to motor weakness. For reasons other than the ones given on the list, they are coded 7. The reason for coding 7 must be specified in the space provided. The patient's comprehension is assessed in 6 tasks. Across the assessment for each of these tasks, the examiner is asked to provide a score for the comprehension ability of the participant. Due to the increasing complexity of task instructions over the 6 tasks, there may be differences in the participant's ability to understand each set of instructions. Therefore, the examiner should enter a comprehension score at the time each task is performed. An overall impression of comprehension ability is obtained from of these 6 ratings, entered at the end of the examiner's booklet, item 23. In general, it's advisable to record any additional qualitative observations of participants' verbal reports and behaviours during the tasks. This information is important in adding to the clinical impression of the participant's performance. Each correct item is given 1 point unless otherwise stated in the subtest scoring criteria. We will now discuss and demonstrate each task one by one, highlighting specific considerations. But again, please refer to the examiner's booklet to make sure you're aware of the full details of each task.